So we're going to talk about knee pain and some of the different causes of knee pain, and then really focus the majority of the presentation on arthritis and knee replacements, partial and total knee replacements. So I'm a board-certified orthopedic surgeon. I actually have an added certificate in sports medicine. I did a fellowship in Baltimore, and I've been in practice since 1999. The majority of that time has been in Richmond. I chair some national committees and served as an editor for a journal. And I teach a lot of advanced knee and shoulder surgery courses to orthopedists around the country. So what are some of the different causes of knee pain? Well, you can have torn ligaments, torn cartilage. You can have just sprains and strains, overuse, or arthritis. And this is a little picture of a knee right here, and you've got your thigh bone, which is called your femur, on top, your leg bone called the tibia on the bottom, and then this white stuff that you see on the ends of the bone is cartilage. That's the articular cartilage that helps to protect the bones, and when your knee moves, it allows it to glide smoothly because it's so smooth in that area. It doesn't have any friction. And then in between the bones where that cartilage is, you have this other type of cartilage called a meniscus, and that's kind of like a shock absorber between the two bones. Now, ligaments, you can think of those as like a piece of rope that connects the bones together. So here's one here. There's some in the middle of the knee, like your ACL and PCL. And when they stretch, you can sprain them, and if they stretch enough, they can tear, like right here. The ligaments help to stabilize your knee, while the meniscus is a shock absorber, like we talked about. It really cushions the joint and allows for a lot of give when you're doing activities like twisting or running or jumping types of activities. And when you develop a tear in your meniscus, you get pain and swelling and catching, and we generally prescribe anti-inflammatory pills or a cortisone injection. Sometimes we'll order an MRI, which in this case shows a torn meniscus right back here. This is the meniscus, and you can see it's almost like when you take this side view of the knee, it's like a little wedge in between the bones. Well, unfortunately, the tears in the meniscus don't usually heal. And so either you live with it and the tear gets bigger and it starts to rub on the cartilage, which is this white area right here on the end of the bone. And so it starts to rub that away because the torn piece is moving around. So you can almost think of it like a little marble in there pushing and wearing down the cartilage. So if you do have it treated, if we get this early enough when you don't have a lot of arthritis, then you could have arthroscopic surgery with a little camera to go in and trim out the torn piece. This is what the cartilage, here again is the cartilage. This is exactly what it looks like arthroscopically when we're looking in there with a camera, an arthroscope. Now here's a case where you've got some cartilage that's worn down to bone. And sometimes people ask me, well, can you transplant cartilage? You hear about things where they grow cartilage and put it in. And yes, we can do those things. The only time we can do them, though, is when you have a very discrete lesion like this. So around it, all that cartilage around it is very normal appearing. But right in here, you've got this area where it's worn down to bone. And so if you have a situation like this, then there are things that we can do to help create or restore cartilage in that area. Now, unfortunately, when you have arthritis, you've kind of got cartilage loss everywhere, and it's kind of very diffuse cartilage loss. So it would be impossible to go in and patch this up with a lot of little patches, so to speak. It would be like a quilt, but it wouldn't work very well. Think of it like the tires on your car. When the tire tread goes bald, you couldn't put a bunch of patches on there and fix it. So you have to have a replacement when you get to this point. So arthroscopy, again, I think we talked about that. That's the small incision, the pencil-sized instruments that we put in there to help treat problems that are like torn ligaments and cartilage and things like that, but we can't fix arthritis. So here's different things that we can do: rotator cuffs, torn cartilage, shoulder ligaments, loose pieces of cartilage in the joint. But arthritis, the most common one is osteoarthritis, which is basically the wear and tear type of arthritis that the majority of the people have. And if you live long enough, everybody will essentially have it in some joint in your body, because it's just wear and tear over time. And the cartilage wears down, and that's what arthritis is. Some people think that it's something that grows on the bone. It's not a growth, it's actually the wearing down of the cartilage. And these symptoms can develop suddenly, or they can develop slowly over many, many years. Sometimes patients say, you know, I hurt myself and now I've got pain in my knee, and I'll x-ray it and say, well, you've had pretty bad arthritis, it's been there for years. And they'll say, well, it hasn't ever bothered me before. And that's very true. If it gradually develops over a long time, you kind of get used to it and you live with it and you don't notice the impact of it, and then something happens, or sometimes nothing happens, and all of a sudden it starts to hurt. And then you come in and you usually have pain. A lot of patients report stiffness in the joints, swelling on occasion. Sometimes very simple tasks can be difficult to do, like standing from a seated position, going up and down stairs, trying to pick up something on the floor. You know, a lot of very common things can become challenging and difficult to do and become frustrating. So let's talk about the non-surgical options first, because this is always the first line of treatment. And, you know, diet and exercise. Of course, every doctor says diet and exercise, but sometimes that's not so easy to do if your knee is very arthritic and you can't, you know, move as much as you want to. But certainly diet and exercise can help, particularly when you have milder forms of the arthritis. Sometimes in those cases also physical therapy, if you haven't been using your leg or you've been favoring it for a long time and it's gotten weak on you, sometimes some physical therapy can benefit you. There's medications like all of us know about, Aleve and Advil and Motrin and all those things that you can take over the counter. Those are anti-inflammatory medications, and those can help with arthritic symptoms. If you're not able to tolerate those types of medicines because of stomach problems or kidney problems, then you could take like a Tylenol arthritis, and that's another option in terms of medications. Then you've probably heard about glucosamine and chondroitin sulfate and some of these different things that are advertised in the pharmacies and grocery stores as replacing cartilage or growing new cartilage. Well, it doesn't do any of that, but for some reason it does help people with arthritis symptoms. And they first discovered this years ago in dogs, actually, where they used to give glucosamine to dogs that had bad hips and things. And so it's been around for a long time. It's a supplement, so it's not a drug. It's not regulated by the FDA. So if a patient's interested in trying it, I just say go to Costco or Sam's Club, get the biggest, cheapest bottle, and try it for 6 weeks or so. And if you're feeling better, then that's great. Keep doing it. If it's not helping you, then there's really no downside. You just stop it. Then you've heard about things like cortisone injections, and some questions that I hear commonly from patients are, you know, are they bad for you? How many can you have? How long will they last? And do they hurt?
That's true. That's what I would want to know.
So that's all the questions that people want to know. So are they bad for you? If you have a joint, if you had a normal joint, let's say you were 30 years old and you had a pretty normal knee, but you injured it, and I gave you a cortisone shot, and then I did it again a month later and a month later, and you know, over time, every time your knee hurt, you would come in for a long duration, then that would be bad because the cortisone can cause some of the normal cartilage to wear down if you do it repeatedly over a long period of time. If, on the other hand, you come in with arthritis already in your knee or other joint, then cortisone is a great option to help reduce the inflammation and pain. And because your goal with arthritis is to be able to function and do the things that you want to do until a point where cortisone and pills and things aren't helping you, then surgery is the option. So the cortisone is not going to cure the problem. The arthritis is not going to go away. Unfortunately, it's going to progress over time no matter what. So if cortisone helps you, and they generally, if it's going to help, it generally will last 2 or 3 months. But again, the worse disease that you have, the less it'll help you. It won't last as long. So that's something that we can't really predict how long it's going to last. But certainly if it was only helping you a short period of time, you wouldn't keep having it over and over again. So, and does it hurt? It's like a sting. It feels not much different than a tetanus shot or a flu shot or anything like that, particularly if you have an orthopedic surgeon give it to you who's very experienced in giving them. And so it's just a 2-second thing. It's very simple. It goes right in. We kind of freeze up the skin beforehand, but it's a very straightforward process for giving the injections.
Can you compare that to hyaluronic acid?
Yep. So here's the next slide on hyaluronic acid. Good question. That was a perfect lead-in. I planted them back there in the audience. So hyaluronic acid, or hyaluronate, is another type of injection. Generally, it's 3 injections, so 1 a week for 3 weeks. A lot of different companies make it. You've probably heard of it as a Synvisc or a Hyalgan or an Orthovisc or Euflexa, some of the different brands that are out there. Synvisc actually makes one that's a single injection, so they tried to combine them together for 1 shot. So my experience has been that the 3 injections work the best and last the longest. I've had some patients that wanted the Synvisc one, and we've done that, and I haven't felt like it's lasted them as long as the 3. But those are all options for you. In terms of how long, I think a great situation, the ideal would be you get the 3 injections, it starts helping you after the 3rd one, and it lasts you at least 6 to 9 months, sometimes as long as 12 months. And then you can have it done again. And it's not cortisone, it's not a steroid, so there's really no downside structurally to having the injections. It doesn't rebuild cartilage, but it kind of helps to cushion the cartilage. It's a higher, what they call molecular weight, so it's a heavier substance than like a cortisone injection, and so that's what helps to lubricate the joint for you. And so you can keep having that every 6 to 9 months as long as it's helping you. And unfortunately, at some point, it will stop helping, and then you can look at a replacement of some type. If it doesn't last just 6 months, then most insurance companies and Medicare will not approve it any earlier than 6 months. So it needs to kind of help you that long to make it worthwhile. Do they hurt? They feel the same as the cortisone injections. Maybe people feel a little more pressure in the knee when I'm injecting it just because it is a little bit thicker material. Sometimes you'll hear of people calling it a gel injection. It's not really like a gel like you would think of. It's still a fluid that's pretty easy to inject in there, but it just gives you that sense of fullness a little bit more than a cortisone injection. All right, so knee replacements. So here's some myths and truths about joint replacement surgery. So knee replacement implants are only good for about 10 years. That's kind of a rumor out there. Well, the good news is that more than 90% of the modern knee replacements are lasting as much as 15 years, and more studies coming out recently are showing that they're lasting 25 to 30 years. So the implants have improved a lot over the years, and they're doing better and better with longevity. Now, there are people that will have loosening of an implant before that time and have to have a revision type of a surgery. So that can happen, but it's much rarer nowadays than it used to be. So 85 to 90% of people should have a functioning knee replacement at 15 plus years. So that's good. I'll have to stay in the hospital a long time after joint surgery. This was probably a slide from years ago, but most people know nowadays that you don't really have to. Most patients go home after the second night after a knee replacement. So do them on a Tuesday morning, you stay Tuesday night, Wednesday night, go home Thursday. So that's the majority of the patients. Some patients will occasionally stay till Friday, so 3 nights. So not nearly what it used to be when patients stayed a whole week in the hospital. We get you.
You mean your own or a nursing home?
On your own, we want to send you to a nursing home.
You mean a rehab facility?
Unless you came from a nursing home, but
Yeah, what about a rehab?
It's a different
center or
floor.
something like that?
yeah, so very rarely for 2 reasons. Number one is most insurances will not approve rehab for someone that has a single knee replacement. If you have them both done, then there's a better chance that the insurance would approve it. The second reason is most patients are able to get around pretty well, and then we have home physical therapy come to your house 3 days a week to work with you in your own home, practicing walking and things like that. So it's very, very rare that anybody goes to rehab anymore. Not to say that you couldn't if you were coming along slower or something like that. It could be an option, but that's the majority of the patients go home.
Well, if you don't have anybody at home to help you, if you're all by yourself, you might need to go have some rehab somewhere.
Yep, that's a good question, or a good point that you're making. So yeah, if you're all alone and you don't have anybody there to help you, then you might be a candidate, and the insurance may approve it. But sometimes I've had some patients like that, and the insurance didn't approve rehab, but they only approved like a nursing home facility. And there may be some really great ones out there, but some of the ones that my patients have gone to we're not very happy with. So it has gotten more difficult to get Medicare or any of the insurances to approve rehab because it costs them more money. So after the replacement, you can't really do exercises or participate in any sports after joint replacement surgery. So that's a myth. So being active is actually encouraged after your knee replacement. In terms of what's appropriate, it depends on whether you had a partial or a total a little bit. But in general, people can get back to golf, doubles tennis, swimming, obviously, walking, those types of things. Now, you're not going to be, probably are not going to be playing a lot of basketball, maybe not soccer. You could play softball. There are a lot of activities that you could get back to doing after replacement surgery. With the partial replacements, they feel a little more natural, so people can get back to more activities. And we're going to talk about partials in a minute. So there's 3 different compartments. 3 different compartments in the knee. So here again is the knee joint here when you're looking straight on. You have an inner compartment here between the bone and the bone down here and the meniscus and the cartilage in between. You have an outer compartment called your lateral compartment. And then this is a side view of the knee. Right, here's your kneecap, and right behind the kneecap there's also cartilage. So this is the 3rd compartment called your kneecap compartment, basically. So the reason I tell you that is the compartments, the number of compartments involved is what helps us determine whether you need a partial or a total knee replacement. So this is what it looks like on an x-ray. So you see the space between the bones on this normal knee x-ray. That's not actually space, it's where the cartilage is. But cartilage doesn't show up on an x-ray, so it looks like a space. So that's a pretty healthy looking knee. Now this one over here, you can see on this inner part of the knee, there's no space. See how it's worn down, bone against bone. And gradually, with that rubbing over a long period of time, the bone will even erode slowly with time, and that's where you see people that get really severely bow-legged or something like that. So when we do a knee replacement, we replace the end of the thigh bone, so just the very end. We don't cut out the whole leg or anything like that. We just kind of shave off the damaged area, and then we put this piece on there, and this is made out of metal. And then we do the same thing on the leg bone or the tibia. We put this piece in here, and then in between you have this plastic liner that kind of replicates the meniscus. It's a very high strength plastic, but it is a plastic, but it glides very smoothly, and it has great, it's very frictionless between the metal and the plastic. But it's metal and plastic, essentially. The metal is a titanium alloy, and most of the time, some will go off in the airports and some won't. And they just wand you and they know you had it. And now with those scanner things, I think they can tell that you've had a knee replacement or a shoulder or whatever. So there's no card that you get or anything like that, because after 9/11 those cards didn't work anymore because anybody could make up a card. This is what the x-rays look like. So we've got this piece here, we've got this piece here, and again you see that space in between, and that's where that plastic liner is. So it really restores what is normal in the joint. And this is just a side view of it, and so right behind this kneecap there's also a little plastic piece that's attached to the kneecap. So we don't take the kneecap out, we're just cutting away the arthritic area and putting a little plastic button on the back of that. So your kneecap will look the same. So Stryker makes a implant called the Get Around Knee, and I started using it about 5 years ago. I was using another make at that time, and having some patients that are having difficulty getting some of their range of motion back, bending and straightening the knee. And so I started looking at other options, and the Stryker knee has what's called a more natural circular motion. I'm going to show you a little video if this will play. So if you look at that circular action of the knee, this is what normally occurs, and this is what occurs when you have the Get Around knee. But some of the other systems have a varying radius of curvature, and so you get this oblong kind of movement, and you can kind of see how it kind of slides and moves. And it's a little less natural feeling, and sometimes patients have a little more difficulty getting all their range of motion back. So that's why I chose the Get Around knee in Stryker several years back. Some people will ask about implants specific for females, and some companies even have specific marketing for that, where they're like, we have gender-specific knees. Really, the main difference between a male and a female is that the female bones tend to be a little narrower. So when we size the different options for you, there are so many different options that are available to the surgeon when we're doing the surgery that we fit it specifically for your knee. So all of these implants come in narrower and wider options. So it is very specific for your knee. It's just not marketed as a gender-specific knee. So one of the things that I started using also about 5 years ago was computer navigation in the operating room. And basically, this allows me to get a very accurate alignment of your knee and your whole leg, actually, because we navigate from your hip down to your ankle. And this is basically like a little GPS device that's in the operating room. And I can see all of this on the monitor. I get your alignment, and you see all these different numbers and things here, so I know exactly how much of the bone and cartilage we're shaving away and making sure that it's perfectly straight or in alignment with your own natural alignment. So, yeah, it's got the GPS that acts kind of like little satellites almost, so I get instant, like, as I'm doing the preparation, I mean, I can just move like this or this, and you instantly see the numbers change on the screen. So I like that for a lot of reasons. I think it's more accurate and reproducible, and it restores your normal anatomy, which theoretically should help your function and getting better and being able to do the things that you want. So, yeah, I already said that. So potential benefits to you, it's a little bit less invasive because generally with the traditional designs, what we did was put a rod into the middle of your thigh bone to help get the alignment. So it went all the way up where your bone marrow would normally be. And then at the end of the surgery, there could be some bleeding and other things coming from that. So by reducing that alone, I think patients feel a lot better after the surgery than they would if they had that rod put in there temporarily. I think you get less bleeding too. I feel like it helps patients to get their range of motion back. Now, it's hard for me to tell how much of that effect is from the computer versus the get-around knee. I think they both contribute to it, but I switched to both of those about 5 years ago, so I've been very pleased with that. Sometimes people ask me, does it cost any more? No. It costs the hospital money to buy that computer, but it doesn't cost you or your insurance company anymore. The only codes that we have are for knee replacement. There's no such code as knee replacement with navigation. So the cost is the same.
Do you put a backup camera in there?
A backup camera? That'd be good. So this is kind of just very generically what a knee replacement entails. It takes me a little bit longer than that to do it, but that's basically what it entails. Now you see the movement of the joint. So we're just cutting out the arthritic part, not, sometimes people will think, are you going to cut my bone up here and down here? That's not it at all. We're just taking this arthritic area in here that's worn down, and we're going to kind of shave that away. We make these special shapes so that this fits on there basically like a glove. There's two ways of securing those implants. Yes, sir?
I was told something would beat into your lower leg.
Something would go into your lower leg?
Yeah.
Yeah, if you look in here real carefully, there's a little tiny fin that goes in there, but it's not like all the way down your leg or anything. So right in here, there's going to be this little fin that goes in there. So on the underside of this, there is a little short stem or a fin that kind of slides in there, and that just helps preventing it from rotating while it's healing.
Beat him with a hammer, so to
Yes, they say it beat your silly beat that.
Yeah, the whole thing actually is, even this piece here, because what we're trying to get is a very tight fit. We want it to be secure. There's two options on how we secure that to your bone. One is an implant that is porous and bone grows into the back of the implant. The other is to use a grout called bone cement, which is really the same material as plexiglass. And we put that grout in there, and then we hold those in place while that grout dries over about 15 minutes or so. The downside, in my opinion, is that the areas where you see failure long-term is usually between those surfaces. So it's either between the bone and the grout or the grout and the artificial implant. So you've got more surfaces that you're dealing with that can fail. And so I use the porous coated, it's called a press fit, that fits on there perfectly, and then the bone grows right into it. So you get a very secure long-term solution.
How long does that take for it to heal?
It starts immediately, and because of the other design on here, it has enough stability until bone grows in there.
So you don't do anything to the ligaments. The ligaments are still stretched and they come back together.
Yes, the ligaments and muscles are not affected. The only ligament that is affected in the middle of your knee is the ACL, which goes from here down to here, and so that has to be removed. But the design of these implants take that into account so that it's not shifting like it would normally if you didn't have an ACL.
So not having an ACL is a good thing?
It's not a good thing, but in a total knee, it's a good thing. Yes, sir.
I had this knee replaced January February of 13,
Uh-huh.
it hurts like hell. The doctor has the only, Tramadol, 50 milligram,
Uh-huh.
I usually take 6 a day,
Wow.
and naproxen, 500 milligram, twice a day.
Have they told you why it's hurting?
He doesn't know why.
You've had different tests to see if it's loose or
He took an x-ray, I don't know.
just an x-ray? Yeah, there's other, so, I mean, that's bad that you're having the pain. That is generally very rare, but I'm sure all of you have heard of people that maybe have had some kind of surgery that didn't turn out like they expected. What I would look for is a few different things. One is a test called a bone scan to see if there's any evidence of loosening of the implant, and also to look for very subtle amounts of infection. And so a bone scan is not something you can do in the office, has to be scheduled at a hospital or an imaging facility. So that would be one thing that I would recommend that you ask for or see somebody else for. But yeah, there are potential causes of continued pain, loosening, infection. If those alignments that we talked about, on the previous slide are not all, if the alignment is not correct and there's everything is not in balance. So one of the things that once we make these bone preparations, we check the balance of the ligaments and the alignment with your knee all the way straight and with your knee bent. And there are cases where when it's out straight, you get really good ligament balancing, but then when you bend the knee, the ligaments are out of balance. And so that means that the bony preparation has to be adjusted. And so that's something to take into account during the operation. So that could be another potential cause of the symptoms. But you've got options. Don't get frustrated. Yes, ma'am.
I should have had both of them done at the same time, but I chose to do one.
Well,
2 days later after I got home from the hospital, the pain was gross.
really?
If I would have both of them done, I probably would have ate my gum.
Wow. Yes, ma'am.
It's that bad.
Yeah.
If your knee has had ACL surgery,
Mm-hmm.
is it still a candidate for knee replacement?
Oh, absolutely. Yep. So total knee replacement isn't always the best solution for you. It's been considered the gold standard for advanced osteoarthritis, but there are many, many people that have less than advanced arthritis but still have pain. So one of the things is that if you remove healthy bone and cartilage in someone that doesn't need a total knee, then you're again taking away healthy tissues. And so a partial knee replacement is if you only have one part of your knee that's affected and the other two compartments are relatively normal. So there's about 70,000 partial replacements done in the United States each year, and that's probably going to increase as surgeons become more aware of the fact that everybody doesn't need a total. That's kind of like the best tool that we've had for so long that, it's kind of like if the only tool you have is a hammer, then you're going to find a lot of nails to pound on. So one of the only tools that we had that everybody liked, and so we just put in total knees on people that probably could have a partial. And so it's very similar to the total, except it's just one part. So you've got the metal piece and the metal piece and the plastic liner. So here's the difference. Here's the partial, and here's the total where it goes all the way across. So something that's come about really in the past 5+ years is a orthopedic robot. So everybody's probably heard of like the Da Vinci robot that they use for obstetric or gynecological procedures, urological procedures, things like that. Well, now there is a orthopedic robot that allows us to do partial knee replacements, very specific and reproducible, with taking away a minimal amount of healthy bone and cartilage. And what that does is it kind of fills the gap for us. So you have early stages of knee pain that could probably be treated with an arthroscopy. And then you have the late stages where just everything is worn out in the joint and you need a total knee replacement. And then that middle stage, which is where a lot of people really are, is they might only have it on this part of their knee or that part of their knee, or maybe here and under the kneecap. And so there's all different options. You can have partial replacement here, a partial replacement here. You could have a partial just behind the kneecap. So there's lots of different options, and that's where a lot of patients really are. And so we evaluate your x-rays, and we talk to you about your symptoms, exactly what's happening, because that can give me a hint of whether you have some arthritis in another area of the knee. We take all that into account. So currently, it's thought that 43% of total knee patients may only have one area of arthritis. So 43% of patients that have had a total knee may have only had one area that really needed a replacement. Patellofemoral, that's the kneecap disease. Probably about 24% of patients just have disease behind the kneecap, making it difficult to stand from a seated position, going up and down stairs, and you feel a grinding sensation in the front of your knee. That may be the kneecap arthritis alone, and if the other areas look normal on x-ray and when I examine them you're not having any tenderness or pain in those areas, then you could be a candidate for just one. Then there's what's called bicompartmental. So if you have two of these areas, we can still do two partial replacements at the same time instead of just doing a total. The advantages of the partial, the main one is you get to keep your ACL. And so even though the total knee takes into account for the ACL and provides that stability, it's still metal and plastic, which doesn't feel as natural as your own ACL would. So that has some benefits in terms of how your knee feels. But you definitely should not be having bad pain.
Should I be feeling clicking?
Clicking is normal because, again, it's metal and plastic, and so those surfaces are moving. So hearing or feeling clicking is normal, but it shouldn't be painful clicking. So the way we do this is there's one additional step. We send you for a CAT scan of your knee. And the CAT scan is, the data from that CAT scan is imported into the robot's computer. And then very similar to what you saw a minute ago, except this is all done prior to me beginning the surgery. We can go in there with these different implants and we can look at different sizes. We can look if it needs to be this way or that way. I can turn this whole thing around 360 degrees on the screen. It's just a computer, and see it from all different angles in there. So it gives us really a bird's eye view of exactly what the replacement is going to look like in your knee, exactly how the bone needs to be prepared for the artificial pieces. And then what we do is we import all of this data and we save it in there, and then this is done like right before your surgery. It's not like days or weeks in advance. So then as we get you prepped and everything, the surgeon is still doing the surgery. So I'm still doing the surgery. I'm not off somewhere with there's not like a robot doing your surgery. It's a robotic arm. And so what that does is I basically see this on the screen, these green areas, and I go in with a device on the robot and we prepare those areas to shave away the damaged cartilage and bone, but just enough to what you need to have the implants put in there. And the way it works is if I try to go outside of the lines, the robot stops. I mean, it will not let you go beyond what you need to do. So it's basically like coloring.
So in your pre-plans, are you using a particular shape just in the knee?
Yes.
Has that been inputted into that so that it's recreating its exact space it needs for that particular piece?
Yes. Yep.
So you're not using the 3D imaging to create the actual piece, you're just accommodating the pieces that you have at your disposal?
Correct. Correct. So this is kind of what it is. We're in there kind of sculpting away this bone, and I can see everything on a screen, but if I go outside the lines, it won't let me. And this is kind of what the implant looks like.
And that's a partial.
That's a partial. Yep. Here's a little animation. It's kind of brief, but so that's the robotic arm right here. This is the computer. And this arm weighs like 150 pounds, but when you use it, it just kind of glides until it stops you. So there's the CAT scan information that's put in there. So again, we were talking about that gap balancing the gaps between the knees and when it's straight and flexed. So we look at all that on the computer, and then we double check it when we're in there. So this is the little device that we use that kind of prepares everything, and I can see it on the screen in green. So I know that I've taken just the right amount. We do that on both surfaces. Doesn't that look like fun?
Anybody could do it.
Anybody could do it.
Looks too scary to me.
You're asleep.
So that's basically it. Currently, these implants are cemented in place. They don't have them yet with enough stability. You asked about the stability of the knee and how quickly it grows in there. So they don't have the design quite where it's ready for the press fit, but that's going to be coming.
How soon?
How soon? You don't want the cement? I don't know. That's
Pretty soon.
oh.
We just turned.
It has been approved,
It has been
FDA approval,
approved.
but it's not ready for use yet. So it is,
It has been approved, yeah, we just heard yesterday.
So you think within a year? Should be. And we were dealing with the FDA, so.
Because I was told that the cement can like crack or come undone or something like that.
Right, that there is a theoretical risk of that, cracking or coming undone, but I would tell you that the vast majority of orthopedic surgeons still use cement.
Yeah.
I mean,
That's the standard.
that is still the gold standard, is to use cement. So I'm not trying to tell you that, oh, that's an awful way of doing it. That is the gold standard. I think back in the day, we used to do press fits only for people that were younger. So we're like, oh, well, they're younger, they're going to need their knee longer, so we'll do the press fit. Well, young is all arbitrary at this point. I mean, people live forever. So, 70 is young if you're going to need that knee till you're 100. So, I mean, it's 30 years you got to live with it. So, anyway, so that's why that was one of the big reasons where I switched to the press fit, because I was not good at predicting how long someone was going to need their knee. That was a different specialty, a higher specialty that I have not been good at. Although there's always jokes about surgeons having a God complex, but So yeah, some of the potential benefits of this Makoplasty are improved surgical outcomes, less implant wear and loosening because we've got the anatomy recreated perfectly for you. It's bone sparing and tissue sparing. We're able to preserve the ACL ligament and the PCL so it feels more natural to you.
is it likely that the other compartment will need to be replaced?
Good question. Right, so he asked, would the other compartment need to be replaced in the future? It depends. So if your other compartment continues, just like with a normal knee, if it wore down over time, then yes, that's possible. And that's where we have to use a judgment. I mean, if it looks completely normal or just a little scuffed up, I think you can still have a partial. But if you're already having some arthritis in the other compartment, then I would, have the total. And we usually know that pretty well in advance of surgery, but in case there was a surprise, that could be done. The other thing is people ask, well, if you have a partial and later you wear out other parts, does that make the knee replacement more difficult? And I think particularly with this being so limited in terms of how much bone is removed, it's really like having what we call a primary knee replacement instead of a revision. And a primary is different than a revision because it's got, it's just designed differently. So you would still be able to probably have a primary, depending on the amount of bone loss and things that you have. All right, so here's some questions that I've heard in previous talks, so I decided to put them into a slide. How do you prepare for a knee replacement? So what we do is we schedule you to have a medical clearance with your family doctor just to make sure everything is okay, there's nothing we need to tune up. I recommend that if you haven't seen a dentist in a while to go ahead and get your dental work, and the reason is after the surgery, after you have a knee replacement, we like you to take antibiotics with any dental work. And that seems surprising, but the worst germs are in your mouth. A human bite is worse than a dog bite. And so we have you take antibiotics. And ideally, we'd like it if you didn't have to have any major dental work done for, at least 3 or 4 months after the surgery. So if you haven't been in a while, probably just getting it checked out. If you have some tooth problems, definitely getting that checked out in advance so that you don't have to take any undue risks. We like to, have your medical doctor make sure that your blood pressure and if you have diabetes, it's controlled. Then we send you to the hospital for some pre-admission tests and labs and EKG. If you're having that partial knee replacement, you would also have a CAT scan done. And then we generally recommend that you go to the hospital's joint class where they take you up on the joint replacement floor. Nurses talk to you about what to expect with the operation and afterwards, and kind of gives you a sense of feeling a little bit more comfortable with where you're going to be, so it's not so much of a surprise when you get there. So I think that's, most patients find that very beneficial. So how much pain are you going to have after surgery? That's a question, right? And this poor gentleman is still having pain, unfortunately, but so some of the things that we do is I have the anesthesiologist give you a nerve block in your leg. And that's done before the operation, and it helps to numb up the leg. And the reason I think that's beneficial is the more we control the pain even before the surgery, it's called preemptive analgesia. The more we do it preemptively, the better pain control you generally have after the surgery. So we have them do a nerve block. There's some pills and things that you take the morning of surgery to also help with pain. There's 3 different classes that we give you to kind of take those pain receptors from all different angles and kind of get that pain as much under control as possible, so that hopefully when you wake up from the anesthesia, you're not having terrible pain. You're pretty comfortable. Get you a chance to get to your room, and then there's pills and medications that are available for you to take, and we have the nurses and the nurses are trained in this to really kind of stay ahead of that pain for the first couple of days. Again, making you more comfortable, allowing you to move the knee better, and being prepared for the physical therapy. So that's the next thing. We get you up moving. It's not laying around for a week in the hotel. We get you moving. And this helps your overall outcome. It helps you to get better, get stronger, walk normally, all of those things the faster we get you moving. Also reduces risks for things like blood clots. So that's real important. We use cryotherapy, which is basically ice that also helps with swelling and discomfort. But generally, if you have surgery on a Tuesday morning, the therapist is getting you out of bed Tuesday afternoon. Maybe you won't take any steps. Maybe you'll just sit up on the edge of the bed. Maybe you'll take a few steps to a chair and sit there for 10, 15 minutes. I mean, it's not going to be anything excessive, but just kind of getting you moving and getting you used to those things. And then you get more therapy the next 2 days, and then you go home and have physical therapy come to your house, or you could, consider a rehab facility, or a skilled nursing facility. They're all options. Most patients go home with pain pills, so we do give you pain pills, plenty of them to take. And so the therapy at home is usually 3 days a week. And then once you're getting from walking with your walker to just walking with a cane, then we generally send you to outpatient physical therapy where they have more equipment. I would say for the partial knee replacements, most of them are going straight to outpatient therapy and not really needing the home therapy. Or if they do need it, it might only be for a week or so. So walker, generally people are using them for a week or two. Some people get to a cane almost immediately, but definitely by 2 weeks, most people are walking with a cane, and they might use that for up to 4 to 6 weeks from the time of surgery. You're allowed to drive whenever you're able to walk with a cane. So you have the walker initially. Well, when you're on a walker, you're probably not safe enough to drive yet, but once you're getting around. Yes, ma'am.
Stairs, if you have stairs that you've got to deal with when you get home, and if you're alone, that's really worrying me when I get home.
Right, so her question was about stairs at home and, you know, what's she going to do if she lives alone. So yeah, that would be a little bit of a challenge being alone. Now, when you're in the hospital, for the physical therapist to say you're cleared to go home, they practice with you on stairs in the hospital.
You can't.
You can't leave until you can do stairs.
A lot of stairs.
You have a lot of stairs? So yeah, so the therapist works with you on that, and then the home therapist, depending on the day of the week that you're discharged, but if you're discharged like on a Thursday, the home therapist will come to your house on Friday.
You
They
really,
have to put a bed
yeah,
downstairs.
you really can't go home alone for a while, really. You need somebody there for a while.
Well, that's a good question. So do you need somebody at home for a while? And that varies to a certain extent because everybody, you know, like you have a lot of stairs, you may have other situations in the house that you might need help with. A lot of people, if they've got family, friends, people from church or synagogue that can help, you know, it's kind of like getting food, and some of the basic necessities are important.
Now, I think you do get help with food and that, but somebody staying with you for all night and that, you need somebody.
No, you don't generally need someone to stay with you all night. You should be, you know, well enough to be able to get up and go to the bathroom and do those things by yourself. So you don't need someone 24 hours a day.
That was what I was going to say.
Yeah.
How do you take care of yourself when nobody's there?
Right. Right. I mean, you know, ideally maybe the first night or so, if you could have someone stay with you, that would be beneficial, but I don't think that's a long-term thing where you need them for weeks or anything like that. All right. All right, so conclusion. So my goal is to offer the least invasive procedure that's going to provide you with the desired outcome. So if you only need an arthroscopy, that's what we're going to do. If you only need a partial, then that's what I recommend. And if you need a total, then we do that. I think the robotic and the computer technology has really improved the way we do these over the past several years, and I think that technology is only going to get better and better over time. But it's really very good now, and these implants, like I said, last for a very long time. So thank you very much.